It just gives me that one option. And let's see, can you hear me now? Yes, okay, great. We just had to switch microphones, then speakers. That makes a little bit of a difference sometimes. So thank you for letting me know that. And that's great. So that being said, we'll go ahead and jump into our presentation. So we do have an introductory slide that we use now, because we do enroll people into the program every 2 weeks, and sometimes people have never used this format before. Maybe they've downloaded the app to their phone, and so they're trying to attend webinar on their phone, and they're not sure how to interact with us. So that being said, the way that you interact with us depends on if you're in the app on your phone or on your computer. Either a desktop or a laptop, maybe even a tablet would look the same, because you'll be in a browser window on those. So on your phone, if you're using the app on your phone, you want to look on your screen to the little section at the bottom where it has screen and audio, and then there's a little box called questions. It has a big question mark and it says questions. That is the box that you click on in order to get this other box to open up, right? That says questions at the top. This is the box that you use to interact, whether you're answering a question that's presented, whether you're asking a question about the question or some other topic, or making a comment, right, to myself. I will respond to your question or comment verbally to the class, so that everybody gets the benefit of your question. Please recognize that questions are very, very much welcomed here. We want you to ask the questions about the questions. I promise you, somebody else has the same question, and they are very grateful that you're the brave person to ask the question, so they didn't have to, right? So please don't hesitate to ask questions, be the brave person. In that big questions box, you'll see at this bottom section down here, it says enter message in really light letters. That's where you would type in whatever you wanted to say, whether it's answering a question or making a comment, and then you hit send, and it shows up on my side, right, so that I can respond. The chat feature is not enabled, right? So you cannot use the chat feature to talk to us and or to other people, right? You can only ask questions to the presenter in the GoToWebinar presentations. Now, if you're on your computer, it's a similar kind of setup. There's a little dialog box here that looks like this when it's collapsed. Then when you open it by clicking the very top little orange arrow, it'll open up into this, and it has basically this little box right here, right? And so you just type in right here whatever you want to say, you click send, and it sends it over to me, right? So that's how you interact. It's the questions box, not the chat, okay? Every week we get people emailing us, I didn't know how to interact. That's why we put this slide in, right? So hopefully everybody that's logged in now knows how to interact with us. So that being said, let's move forward. The first thing we like to talk about before we jump into questions after that is the way that the NCLEX is broken down, how it is organized. So you're currently learning your study, if you are a first-time tester, by the body systems and the disease processes, some procedures and things that are associated with those body systems to build your foundational knowledge, to refresh what you learned in nursing school, remind you of what you learned in nursing school, get you back to that just graduated state of mind. But the actual exam is not organized that way. The actual exam and your adaptive exams in Nurse Achieve are arranged by the client needs categories. There are 4 primary categories, and 2 of them have some subcategories. So the first one, safe and effective care environment, is made up of management of care and safety and infection control. Then you have health promotion and maintenance, psychosocial integrity, and then physiological integrity is made up of 4 subtopics: basic care and comfort, pharmacological and parenteral therapies, reduction of risk, and physiological adaptation. And you can see the percentages for each of these categories here. Now, the way the questions are pulled and presented to you in your adaptive exams and on the NCLEX is not category by category, right? They're going to be all jumbled up. You're going to get a question from management of care, and then a question from pharmacology, and a question from safety, and a question from psychosocial, and a question from health promotion, a question from physiological adaptation, a question from reduction of risk, and it's going to just jump around all over all of the categories, right? There's not going to be a way for you to predict what the next question is going to be about, okay? However, the entirety of the exam, if your exam closes at 85 questions, the breakdown by category percentage-wise is going to be these lower numbers of the percentage ranges for each of the categories. Then as you answer more questions, depending on how you're doing in each of these categories, you will get more questions in the ones that you are getting more questions wrong, getting lower difficulty questions. They will start presenting you more questions all the way up until you get to question 150. When you get to question 150, your breakdown is going to look like this, the higher percentage of questions in the exam. Now, if your exam closes between there, 85 to 150, you're going to have a percentage somewhere in the middle of the range, right? In between the highest end and the lowest end of that particular category. And that being said, when you look at this breakdown, if somebody asks you what part of the exam is bigger, where do you get more questions from? Safety and infection control or basic care and comfort? Well, you would say, oh, there's going to be more questions on safety and infection control because it's a larger percentage, right? 10 to 16 versus basic care and comfort, which is 6 to 12. However, if you are really good at safety and infection control, your total number of questions from that category can stop at 10%. And if you're not so great at basic care and comfort, the total number can climb all the way to 12%. So your actual individual exam could have more basic care and comfort questions than it does safety and infection control, because you got 10% of safety and infection control and 12% of basic care and comfort, right? So it's important to understand that function of the exam, right? Because sometimes people feel like they got so many questions from these smaller sections, and it just has to do with how you answered the questions on the test that day. Now, the concepts that are in the bottom of the screen in the purple section, those are interwoven in between all of the client needs categories, and you can get questions on any of those concepts and any of the categories, right? So that's part of how it is distributed as well. All right, so that being said, today we're talking about psychosocial integrity, which covers abuse and neglect, grief and loss, behavioral interventions, mental health concepts, chemical and other dependencies, religious and spiritual concepts, coping mechanisms, sensory and perceptual alterations, crisis intervention, stress management, end-of-life care, support systems, cultural influences, therapeutic communication, family dynamics, and therapeutic environment, right? So those are the topics that our questions will be drawn from. When you're looking at questions, you always want to think about what's my focus of my question, what approach do I want to take, and what is the style of the question. All of these will help you to think through your questions. What's the focus? Is it a prioritization? Is it therapeutic communication? Am I focusing on teaching and education or pathophysiology of the disease process? What is the topic of the question and the actual question I'm being asked, right? That's what I want to focus on. And then my approach is going to include the strategies, whether it's a delegation, prioritization, therapeutic communication, select all that apply, but also I want to think about looking at my answer choices from the decision tree perspective, right? Working out what is the best option here and looking at them from a logic perspective with that orange in the basket of apples, the umbrella, or the fixed versus flexible language. And then, of course, the style of the question can often help me with determining my correct answers, especially in questions that have a matrix or a drop down or a drag and drop. Like, I can use different aspects of the question to help me with other aspects of the question, right? So I want to incorporate that into how I approach my questions before I make my final decisions. So therapeutic communication, we do stress this a little bit because not only is it a topic in psychosocial integrity, it's also a type of question, and it's also a strategy for answering questions. So we like to stress this a lot because it has three kind of components to it. So we do want to respond to a patient's feeling and tone and provide them correct information without minimizing their fears or concern. We want to address them directly. We want to stay focused on the client, use silence and presence to allow them to think through their thoughts, feelings, choices, options, decisions that they're making. We avoid why questions because motivations and root causes are not what we really are worried about as nurses at the bedside. Our focus is on behavior and decision making. That's it. And then we want to use open-ended questions to help get more information from them about their thoughts and feelings and decision making, unless we're asking specifically about possible self-harm or harm to another person, in which case we do want to use a yes/no question. Do you have a plan? Do you have an intent, right, to hurt yourself or someone else, right? So we want to do all of those things. All right, our 6 steps, of course, we're determining the type of question and what strategy we want to use based on the kind of question we're being asked. What exactly is the question asking me? And then number 2 is what is the topic related to that question? Number 3 is those keywords and clues. What do I see there to help guide my thinking about the topic? And then 4, what do I know about that topic that I can go ahead and put out there to say, okay, these are the things I know to be true. And then use the strategy identified I needed in step 1 to review and eliminate answer choices that are not correct is my step 5. And then step 6, I'm going to reread the questions and the answer choices that remain and choose the best one, right? Remember, frequently in NCLEX questions, there will not be just one correct answer. Like so many people will write back, yes, I took my NCLEX and I always had a hard time on all of the questions choosing between 2 answer choices. That's because they build them that way, right? You have to choose the best answer choice. There's not going to typically be just one correct answer choice when you just read the question straight through. You have to really think it through. All right, so let's look at question number 1. A 25-year-old client is about to go a unilateral orchiectomy for treatment of testicular cancer. The client says to the nurse, I am so worried that my future spouse is going to call off our engagement. What is the best response by the nurse? Should the nurse say, are you concerned about how the surgery will affect your sexuality? Number 2, should the nurse say, if you are concerned about infertility, you could always bank your sperm. Number 3, the good news is that we caught the cancer at an early stage. Or number 4, what have you and your future spouse discussed about your condition? Which of these is the best answer choice for this particular question based on what the patient has said? I'm worried that my future spouse is going to call off our engagement. I always give about a minute to 2 minutes, depending on how quickly people are answering with the correct answer. And you guys are doing a pretty good job here. I'm happy to see that. All right, So our correct answer here is number 4. What have you and your future spouse discussed about your condition? This is an open-ended question that allows the patient to state what the discussions have been that they have had so far. So why were the other ones wrong, right? This is always important that you understand why was the right answer right and why were the wrong answers wrong. So number 4 is right because it's an open-ended question. It allows the patient to give further information about what they have discussed with their spouse and what is the cause of their worry, right? What is it that is causing them to be worried? Number 1 says, are you concerned about about how the surgery will affect your sexuality? That's a yes/no question. Yes, I am. No, I'm not. Right. So that makes that an off limits question because it's a yes/no question and it's not asking about suicide or intent to harm another person. Okay, so that's why we can get rid of number 1. And the patient doesn't address sexuality directly in the question. They just said, I'm worried they're going to call off the the engagement. Why? Well, he's got testicular cancer. It may not be about sexuality. It might be about having to work with them through the cancer treatment. We don't know what the issue is, right? So that's why we have to find out what they've discussed, right? So number 1 is wrong for those reasons. Number 2 is wrong because it says, if you're concerned about infertility, you could always bank your sperm. Well, here the nurse is assuming what the issue might be, which is infertility, and that could be the issue, but we don't know that. The patient hasn't stated that directly. And they're giving a solution to that problem without giving the patient time to talk about what their concerns actually are. So that's why number 2 is wrong, because it's making an assumption and basically shutting down conversation with the patient. It's just giving them a solution to a problem that may not even actually be the problem that the patient is concerned about. So that's why number 2 is incorrect. And number 3, the good news is that we caught the cancer at an early stage. This is what we call a don't worry statement, right? It's focusing on the good thing, right? The silver lining, but that's not what the patient is talking about. The patient is talking about the worries, the not silver linings, right? The concerns. And that's where we want to focus. We want to address their fears and concerns directly, right? That's the therapeutic communication technique. So number 4 is the only one that does that, right? It asks them what they have discussed with their spouse about their condition so the patient can state, these are the things we've talked about. This is what I'm worried about, right? So that's why number 4 is our correct answer. All right, question number 2. The nurse is caring for a dying child on a palliative unit. Which statement by the nurse is most important to make to the parents immediately following the death of their child? Should the nurse say, number 1, finding support with other local grieving parents can be helpful? Should the nurse say, number 2, self-care is important at this time. Take a break while the staff completes care? Should the nurse say, number 3, some parents like to cuddle and speak to the child. Take the time you need? Or should the nurse say, number 4, this must be a very difficult time. How have you dealt with loss in the past? Right? This is a little more complicated, right? So let's think about this. How do we want to respond to this family, to these parents, immediately following the death of their child? All right, this one y'all are a little more scattered on, So our correct answer here, our question is, which statement is the most important to make to the parents? And our keyword is immediately following the death of their child, right? Immediately following the death of their child. So child has just died. What is the most important thing to say to them right now, right? So finding support with other local grieving parents can be helpful. That's a true statement. This is an example of a true statement that's not the correct answer, okay? Not the correct answer. Why? Because this isn't focusing on the right now moment. What's right now? The waves of immediate grief, right? And so finding local support for, processing through the grief is not something that they're focused on right now. Right now, they're just focused on my child just died, right? So number one is not correct for that reason. Number two, self-care is important at this time. Take a break while the staff completes care. The child has just died, right? They have just lost their baby. Many, many, many times, parents want to be involved in the care of their child right after they pass because it helps them with closure, right? It helps them to get through that immediate wash of grief. So sending them away from the child right after they die is not therapeutically helpful. So while it is true that self-care is important, that's not what the the parents are going to be focused on at this moment. Right now, they want to focus on their last minutes with their child before they're taken away to go to the funeral home, right? So that's why number two is not important. Sending them away is not going to help them with this moment of intense, overwhelming grief. Number three is some parents like to cuddle and speak to the child. Take the time you need. What does this do? It gives them space. It gives them an opportunity to get close to their child now, right after they've passed, to work through these last moments of grief, to say the things they want to say as a goodbye, right? And to touch their child, right? They've been doing this all along as the child's been dying. They've been on a palliative unit, but now it's final. This is the last moment, right? The family needs, the parents need this time for these last moments with their child, which is what makes it the correct answer. But number four, this must be a very difficult time. How have you dealt with loss in the past? This is kind of an analysis of, what are your typical coping mechanisms? Not something they want to talk about right now, right? Right now, all they want to talk about is my child is dead, right? So we have to think about, where are the parents in this moment? What's going to be the most helpful to them? What is going to really help them deal with the fact that they've just lost their child? So letting them know they have the time that they need to speak and cuddle their child now that the child has passed, that there's no rush, right? There's no rush from the nurse's perspective. We are going to give them the time they need. That's what we want to do, right? So correct answer is number three for question two. All right, question number three. Which emergency department patient would not be allowed to sign out against medical advice? Select all that apply, right? So you have to think about what makes it not okay for a patient to say, I do not accept this treatment. Remember, in the United States, the right to refuse medical treatment is a basic patient right. So which of these patients would not be allowed to exercise that right? Would it be number one, an 18-year-old in sickle cell crisis receiving oxygen via face mask? Number two, a 40-year-old female who drank a 1-liter bottle of vodka 2 hours ago. Number three, a 22-year-old male who hears voice commands to kill a coworker. Number four, a 32-year-old female with mania who has not eaten in 5 days. Or number five, a 55-year-old male with ST elevation on ECG monitoring. And which of these would not be allowed to sign out against medical advice? So select all that apply. All right. You guys are doing pretty good with this one. Most of you are getting at least 2 out of 3, right? Most of you are getting at least 2 out of 3 of the correct answers. But our correct answers are answer choices number 2, number 3, and number 4. Okay. The reason for this is because number 1 and number 5 are adults. Number 1, they're both 18 years old or older, so they're in charge of themselves. Number 2, there's no indication that they are not in their right mind. Okay, they have a physical issue that needs to be treated, but there's nothing indicated that says that this person does not have all the facts they need, does not know the repercussions of the choices they would make, that is impaired mentally in any way. Okay, that's the criteria. Is there a mental impairment? So Vera thinks that's a good question. She's asking, is 18 years old not categorized as a minor? It is not. 18 years old is the age of adulthood in the United States for most things, right? So there is some caveats to that, but in general, for most things, 18 years old is considered an adult. So they can sign contracts, they can, make purchases, they can, go live wherever they want to, they can leave home whenever they want to, they can do whatever they want as an 18-year-old person. Now, there are some caveats, right? There's certain things that 18-year-olds are not allowed to do. Number 1 is smoke cigarettes, right? In some states, you have to be 19, in other states, 21 years old to smoke cigarettes. Number 2 is drink alcohol, right? Purchase and drink alcohol in a public setting. That is 21 years old across the country, right? Everybody has to be 21 years old. Number 2 is purchase a gun if you're not in, well, no, actually, I think when you're 18, you can purchase a gun. When you're 18, you can purchase a gun. Let's see, the other thing is in some states, people can get married at the age of 16 or older, so they don't have to be 18 to get married. And if they get married at 16 or 17 years old, that automatically makes them an adult, right? So the 18 years doesn't apply anymore because they're married. And in a few states, you can actually be 14 and get married without parental consent. So it just depends on that. Now, the other one is what we call sexual health care, right? Especially has to do with STIs, getting treatment for those. Anyone 14 years old and older can get treatment for an STI without their parents being informed. Now, typically they're on their parents' insurance, and so the insurance would then tell the parent, because they're the payer, that this was paid, right? So they might see it on a bill if they look closely, but the hospital doesn't call and notify them, right? If they're getting treated for an STI, or if they've been diagnosed as pregnant, or if they have sought termination services, right? Now, there's a lot of states in the U.S. that are now making termination services not available if the person's pregnancy is 6 weeks or more, or if the baby's heartbeat can be heard, right? So those are the 2 criteria in most states now. There are some other states that are making other laws. So the abortion laws are very, very fluid right now from state to state, but typically about 14 years old, people can seek an abortion or go to a judge and ask for an abortion outside their parents' permission, right? So those are the big things. But in this particular case, an 18-year-old with sickle cell crisis receiving oxygen via face mask is considered a legal adult. There's no minor or mental impairment. They are allowed to leave AMA. The 55-year-old male with the ST elevation on ECG, likely having an MI, but he is allowed to leave if he chooses to leave. Now, he's probably going to have his heart attack right out there in the parking lot and be back in there in just a few minutes, right? But he is allowed to leave against a medical advice, right? So they just fill out the paperwork and off they go. Now, why are the other 3 not allowed to leave, right? That's important to know. The 40-year-old who drank a liter of vodka 2 hours ago. A liter of vodka is a lot of vodka, y'all. And in 2 hours, you would have to be a huge woman, right? With lots of muscle, right? Really comparable to a male to be able to even tolerate that, number 1, without being seriously ill. And number 2, you would still be significantly impaired, right? You're not able to make decisions under the influence of alcohol like that. So that person would not be allowed to go in AMA. A 22-year-old male who's hearing voice commands to kill a coworker, right? Safety of other people. We do not let those people out into the community if we know that's the case. We have the right to put them on a 72-hour hold and keep them in the psychiatric unit until we can hopefully get them stabilized and they're not threatening to go kill people anymore. And then our 32-year-old female with mania who has not eaten in 5 days. Her mental impairment is jeopardizing her life, right? She hasn't eaten in 5 days because of the mania. So yes, there are people that choose not to eat for religious reasons or other reasons, but they don't have a mental illness causing them to make that decision. They're making that decision out of a rational choice, having thought it through, right? Understanding the implications and making sure they have the proper medical support, etc. But a person with mania isn't thinking about that, right? They're just off in their own world and they're not eating because of the mania, right? And they're putting themselves at risk as a result. So we would want to get the mania under control. Again, 72-hour hold in the psych unit to try to get them back under control with medication. And then once they were under control, we could let them go at that point. All right, question number 4. A new nurse is caring for an adolescent transgender client. What question would be appropriate when assessing the client's gender identity? Should the nurse ask, number 1, do you prefer being referred to as he or she? Number 2, how would you describe your gender orientation? Number 3, what gender were you originally? And number 4, what would you like me to call you? Right? Which of these is going to be the best way to assess the client's gender identity for a client who has identified themselves as being transgender? So in some parts of the world, this may not be an issue yet, but it is something that you will likely encounter when you come to the States, unless people have come back to their senses. Right, so a good number of you are getting this correct, which is great, right? It's really great because this is one of those situations, especially in US healthcare right now, that people are having to tread very lightly because there is this, offended mindset that is pervasive in our society these days, and people get offended over the least little thing, right? And so making sure that we address people the way they want to be addressed is important, right? And so understand, right? One of the ways that you can think about this, because sometimes when you come from a background where this just doesn't make sense to you, it's like, how do I reconcile this in my brain, right? So imagine that someone from the UK came to the US, right? In the UK, they have a societal class of people called the nobility, and certain people have titles assigned to them, and you refer to them as Lord so-and-so or Lady so-and-so. In the US, that system does not exist. So as a person who was born and raised in the United States and has a fairly egalitarian sense of perspective, calling somebody Lady so-and-so as an implication that in some way or shape or form that they are of better stock than I or a higher class than I, is a little bit anathema, right? Like, I'm just like not okay with that. However, if a patient says to me, I prefer to be called Lady so-and-so, what am I going to call them? I'm going to call them Lady so-and-so. Why? Because it's not about my perspective. It's about what the patient wants to be called, right? That's what we want to call them. So it is important to see it from that kind of a perspective. Like, what a person wants to be called is what they want to be called, right? Now, navigating this question, though, can be a little difficult because in the healthcare setting, we do need to know a person's actual biological sex, okay? The sex that they were born with, the sex that goes with their DNA, the sex that goes with their original birth body parts, right? We need to know that. Because why? Different things can happen in a male body versus a female body, right? Like, and so I'll give you a really good example here. And this one is a tragic situation, a tragic example. There was an article, it's probably been a couple of years ago now, in the paper about a person who came to the ER complaining of abdominal pain. The person identified themselves as a male. They, by all appearances, looked like a male. Their paperwork indicated they were a male, but they were complaining of abdominal pain. So they were worked up for male abdominal pain, right? They were screened for ulcers. I don't know. They got, labs drawn, all kinds of different things, right? One of the things that was not done was a pregnancy test. Unfortunately, this person was actually biologically female and pregnant in labor. And because nobody knew and nobody checked and nobody asked the questions, the person ended up giving birth prematurely and the baby died, and actually the person died. They bled to death because of the miscarriage. Why? Because nobody was looking for a baby. Nobody was looking for pregnancy. And it was just tragic, right? That this person and how they viewed themselves and saw themselves ended up costing them their life because they weren't willing to give that information voluntarily, and nobody thought to ask the question. So now, as a result of that situation and probably several others across the country, most healthcare facilities now ask both questions. What is your biological sex and what is your gender identity, right? Because how we see ourselves may not align with the physical body that we're born in, right? And that's true for many people out there. Now, the reasons behind that and how we view that and our explanations for that are multiple and varied and individual in many cases, right? But we have to be able to navigate the situation, right? And call the patient what they want to be called and address their biological physical needs, right? We have to do both. So answer choice number one, do you prefer being referred to as he or she, is not going to help, because some of the people that identify themselves as transgender do not identify as male or female. They identify as what's called non-binary, right? So they prefer to be referred to in the third person instead of he or she, but they, right? So they this, they that, right? Instead of he this or she that, okay? And then if you ask them, what gender were you originally? The word originally can have a couple of connotations. And from the patient's perspective, internally, their subjective feeling may be that they have always been the gender they identify with, but that's not necessarily the gender that their body is. So that's not going to help the way that question is worded. And number 4, what would you like me to call you? A lot of you picked this and it sounds really good, right? Because it's like putting the ball in their court. What do they want to be called, right? We want to call them what they want to be called. So what do they want to be called? The problem is they could say, you can call me Jack. Well, Jack sounds like a male name in many cases, but it can actually be short for Jacqueline, right? There's women out there that go by Jack that are called Jacqueline, or Charlie, and their actual name is Charlotte, right? So just asking them, what do you want me to call you, isn't necessarily going to tell you their gender or their biological sex. So asking question number 2, how would you describe your gender orientation? This allows them to say, this is how I feel about myself. This is how I see myself. And then the corollary question is, what was your biological sex at birth, right? They actually want us to say assigned at birth, right? Because there are truly actual cases of people who are born with genitalia or internal genitalia of both genders or sexes. And so those people are called intersex, right? They have the genitalia of both. And so if they say, well, I was born intersex, but I identify as male, or I was born intersex and I identify as female, right? We need to know that, right? Because this could be a person who has a penis and a scrotum and ovaries, or a vulva and testes, right? We don't know if they're intersex, right? How that's going to play out. So we need to know both questions. So asking, how would you describe your gender orientation, is going to help get you the information you need the best, right? And then you can say, what would you like me to call you? Because then you can get the name they want you to use, right? All right, question number 5. The home health aide reports to the care manager that the client has been trying to give away possessions. When the nurse asks the client about this behavior, the client says, with my husband dead, there is no reason for me to keep trying. What is the best priority response by the nurse? Right? So this is kind of a double-edged question. The best priority response by the nurse. Should the nurse say, do you have friends in the building that you could spend time with? Should the nurse say, number 2, have you had any thoughts of hurting yourself? Should the nurse say, number 3, tell me more about how you're feeling? Or should the nurse say, number 4, you're not thinking about killing yourself, are you? Right? Which one of these should the nurse ask the patient? A lot of you are making a choice thinking you're getting this therapeutic communication thing down. Like, I got it. I know it's this one, right? But we got some clarifications to make about why a different choice is actually the correct answer. Right? I like that, Brian. Brian says one of these sounds kind of judgmental. Like that's why it's not right. Right? He gets that, right? It's very important that you do see those things. All right, so let's look here at this. Our correct answer is actually number 2. So this is an example of a question that really demonstrates why it's really important to think about what is happening in my question. What's going on, right? So if I don't have the answer choices, if I don't look at those yet, if I just focus on the question, what's going on in the question, what am I thinking about? The home health aide reports to the nurse care manager that the client has been trying to give away possessions. Right? And we're going to talk about that, Eveline. That's great. Eveline says, but 2 seems like a yes or no answer, right? And she's right. It does. It is the yes or no answer. So let's talk about that. So giving away possessions, right? When people just suddenly start giving away possessions, that's an actual objective sign of a situation, right? So what's going on with this patient? And so when the nurse asks the patient about this behavior, the client says, with my husband dead, there is no reason for me to keep trying. What do we think is going on? Jonathan got it. A client who gives away his possessions may have suicidal ideation, right? Suicidal ideation. And when the nurse questions the patient, she says, when my husband is dead, there's no reason for me to keep trying. So what am I thinking about? I just need to go be with him, right? Definite example of suicidal ideation. So with our therapeutic communication tool, right, we do avoid yes/no questions. We want open-ended questions, which is what number 3 is. Tell me more about how you're feeling. Unless, right, that's the key word, unless we're asking about suicidal ideation or intent to harm another person. In that case, you want a yes or no answer, right? Yes or no answer. Have you had any thoughts about hurting yourself? Yes or no? Because I need to put suicide precautions in place if that's a yes, right? That's why we want to do that. Let's see. Vera says, what if it's due to religious beliefs? I'm not sure what you mean by that. Right, and Nalini says the patient has already voiced how they're feeling, right? So that's good, right? That's another point, right? This question number 3 says, tell me more about how you're feeling. The patient says how they're feeling. There's no reason for me to keep trying, right? Okay. What if it is due to religious beliefs? Call to sharing. I'm still not certain what you mean by that, Vera. What is due to religious beliefs? Christianity preaches on the act of sharing. Okay, I see what you're saying. So Vera's saying, what if she's just giving her possessions away because she's a generous person, right? She's practicing the Christian value of generosity. And if that were the case, then when the nurse went to ask her about that, what would she have said? Well, I have so much, I want to share it with the people that are around me, right? That's what it would be, right? Like and Jonathan says maybe she meant almsgiving, and that's kind of what it is, yeah. But that's what she would have said, right? She would have said, I have so much, I'm giving away to people that have less than me. Or I don't think I need all of these things anymore. I want somebody else to have them. They're taking up too much room in my apartment, right? Or something like that. But what she says is, with my husband dead, there is no reason for me to keep trying, right? So she's not giving stuff away because she wants to help other people. She's giving stuff away because she doesn't see any further reason for her to keep living her life, right? To keep going through the motions of daily life. So we have to ask then, have you had any thoughts about hurting yourself, right? Because we got to find out how far along on the path to suicide is she, so that we can put in the proper precautions. I hope that helps, Vera. And so that's a really good what Vera's got is, right? So this is one of the things I tell people as they're going to their test on my pre-exam call is, whenever you have those what if and what about questions, that's a red flag that maybe you're starting to add stuff into the question that's not there, right? So that was a good example of that, because yeah, she could have been, right, very definitely giving away her stuff because she just wanted to be generous. But her statement to the nurse is what clarifies that that's not what it was, right? And so that's what we want to go with. What does the question actually say? All right, great job, y'all, and great questions. I think that you're making great discussion. All right, so now we're going to move on to our case scenario, our case study. Remember, in your case study quizzes, in your adaptive exams, and on your NCLEX, there will be 6 questions in the case studies. The first question focuses on recognizing cues, the second one on analyzing cues, the third one on prioritizing hypothesis, the fourth question on generating solutions about what you can do for what you think is wrong based on the clues that you saw. The fifth question is going to focus on actions that you'll take, and the sixth question will focus on evaluating the outcomes. Because we can only do 5 in Question Clinic, at least at this point, we do blend a couple of them, right? Either 1 and 2, or 2 and 3, or 3 and 4, or 4 and 5, right? That's kind of how we do it, right? So just know that we're still following the same process. It's just 2 of them might be kind of hooked together in the same question. So let's look at our scenario. The nurse is caring for DP, a 29-year-old female patient who underwent a laparoscopic appendectomy for an unperforated appendicitis. At 12:30, the client is currently 3 hours post-op. She is awake and alert and oriented to person, place, and time. The client appears fatigued, did not sleep well last night. Her lungs are clear bilaterally and respirations are regular and unlabored. The abdomen is soft with slightly tender upon palpation of the right lower quadrant. The bowel sounds are hypoactive. Her incisions are well approximated. There's no abdominal discharge present, and the dressing is dry and intact. The client reports pain rated as 4 out of 10, and analgesia is administered as ordered. The capillary refill time is less than 2 seconds. Instructed the client about proper incision care. The client seemed irritable and had difficulty concentrating. She reports feeling distressed and extremely anxious. She's requested to be discharged home early. Her medical history is remarkable for general anxiety disorder and panic disorder. She takes alprazolam PRN. Okay. So we have this basic post-op patient. Looks like things are the way they should be, day 1 post-op, but she's wanting to go home early. She's not feeling good. She hasn't slept well, and she has a history of generalized anxiety disorder and panic disorder, and takes alprazolam for those conditions. Her vital signs include a temperature of 36.5 Celsius or 97.7 Fahrenheit. Her heart rate is 98. Her blood pressure is 118/74, and her SpO2 is 100% on room air. Her medications are not given to us at this point, right? So now they want us for question 6 to highlight which findings require immediate follow-up by the nurse. So I'm going to give you guys a little bit of a clarification here in your Nurse Achieve case study questions. When they say immediate follow-up, they are typically looking for answers that address airway, breathing, circulation. That will not always be the case in our questions that we give you and or on your NCLEX. Okay, so be aware of that. Immediate follow-up really can focus on things that are not the way they're supposed to be, that are out of the ordinary, that are not normal, that are concerning enough that you would call the doctor, right? That's what you're looking for. So out of this situation with our patient who had the unperforated appendicitis, 3 hours post-op, the description that we have, what are the things that we would want to follow up on with her being at this point 3 hours post-op, awake and alert and oriented to person, place, and time? What bothers us? Give y'all a couple of minutes to throw some things up there. All right, I'm getting lots of good things here. A couple of things that are actually okay for the situation, so we'll talk about those, but most everything looks normal here that you guys are suggesting, right? So first we want to talk about the fact that the client appears fatigued and did not sleep well last night, right? Did not sleep well last night. Last night was the night before the surgery, okay? So it's not related to the surgery itself as far as the physical act of the surgery. It's about the fact that she didn't sleep well before the surgery. The next thing that we want to look at is that she is irritable and she's having difficulty concentrating and she feels distressed and extremely anxious, right? Distressed and extremely anxious. So all of these are signs and symptoms that actually correlate with her history of general anxiety disorder and panic disorder, okay? Right, all of those. Now, some people would have chosen that her bowel sounds are hypoactive, but remember, she is only 3 hours post-op. She had an appendectomy. She was under general anesthesia. It's going to take a day or two, right, before her bowel sounds are back to normal. At least one day, usually, right? A couple of other people picked her pain, right? Pain at 4 out of 10. 3 hours post-op, not an unusual situation. We do expect that. She was given her pain medicine as ordered, so it's been addressed, right? And is not noted to be otherwise, not getting resolved. So we can say that that's a normal finding as well, right? So those two things are actual normal findings, but these others are not normal findings for a patient who is awake, alert, and oriented after surgery, right? And has no other issues going on with them, right, at this point. Now, a few times I have seen people choose the fact that she wants to leave early, right? But this in and of itself is not a problem. She can want to leave early for a lot of reasons. Maybe she has pets at home. Maybe she, has a job she wants to get back to or whatever. She's just not wanting to be in the hospital for an extended length of time. So we can't say in and of itself wanting to be discharged home early is a problem, but the other things are definitely problems, right? We want to follow up on those. All right, question number 7. Now we want to look at the findings here and determine whether we would expect to see them with generalized anxiety disorder or panic disorder, right? So each of the findings below, select to specify if the finding is consistent with generalized anxiety disorder or panic disorder. So insomnia, Where would we expect to see that? You have to think about what's going on with a person when they have generalized anxiety disorder or if they're having panic disorder, right? So insomnia is typically an ongoing situation. When you think about these two disorders, generalized anxiety disorder is something that's kind of pervasive, like throughout your day, throughout your week, throughout your month, your year, right? Panic disorder tends to be very specifically triggered by situations. So I can go a whole day and not panic, right? I can go a whole week and not panic, but something happens and boom, I'm having a panic attack, right? And I'm getting all, bent out of shape. So insomnia tends to fall with generalized anxiety disorder. How about chest pain? Do people that have generalized anxiety disorder walk around with chest pain? Right, very good. Most of you are getting this one correct. So chest pain would be with our panic disorder, right? It typically mimics a heart attack, right? People think they're having a heart attack when they have a panic attack. How about chills? Okay. So if I have generalized anxiety disorder, do I walk around shivering all the time? No, not really, right? So typically, unless I'm in a cold environment, right? Typically chills are going to be associated with panic disorder. Feelings of choking. Do people who just have general anxiety walk around day to day feeling like they're choking? I think most of you guys get that one is also panic disorder. How about irritability? Very good. All right. Yeah, irritability, that's a pervasive experience, right? So that would be our generalized anxiety disorder. So good job with that one, guys. All right. Now they want us to complete the following sentence by choosing from the list of options. There is no change in our patient's assessment here. Vital signs, looks like she had a change in her vital signs. Temperature is the same, heart rate went up, respiratory rate went up, blood pressure went up, SpO2 went down, right? So the nurse suspects that the client is having a panic attack. It is important that the nurse does what? Contacts the HCP immediately, remains with the client, calls a family member to calm the client, or leaves the room to provide solitude. What do we want to do for this patient who we think is having a panic attack? Excellent, guys. Excellent. Y'all are doing a great job with this one. Very, very, very good. Yes, we want to remain with our client, right? If our client is freaking out, right, we don't want to leave them by themselves, right? We want to stay there with them, reassure them that they're not alone, right? That we're going to take care of them, that we're going to get help for them. We can call the doctor from inside the patient's room, right? We want to stay with them, and then we can call the doctor from inside the patient's room. So definitely remaining with the client is our correct answer. All right, question number 9. Our nurse's note update says at 13:30, we remained with the client while her brother left for a coffee break. The client begins to discuss about her recent divorce and the passing of her mother that happened 2 weeks ago. During the conversation, the client's heart rate and blood pressure began to elevate and is short of breath and diaphoretic. She also begins to tremble and reports that she feels like she cannot breathe. At 2 o'clock, the cardiac monitor reveals that the client's heart rate and respiratory rate continue to rise, and the client complains of tingling of her hands, is visibly upset, and begins to cry and rock back and forth. Cardiac monitor reveals this rhythm with a heart rate of 119. Okay? So now they want us to drag from the choices below to complete the blanks in our statement. The nurse should anticipate the physician to order what and what. Do we expect the doctor to order supplemental O2? haloperidol 5 milligrams, 12 lead ECG, a CTA of the chest, lorazepam 1 milligram PO, adenosine 6 milligrams IVP, IV push, right? Or vagal maneuvers. What do we expect that the doctor is going to ask us to do for this patient? Let's see, I'm getting a lot of people choosing the right answers. That's excellent. A few of you are choosing some other things, so we're going to talk about those as well. All right, so the first thing that we do expect the doctor to order, of course, is the 12 lead ECG, right? Anytime there is a heart arrhythmia of any kind, we want a 12 lead ECG just to, verify what's going on in the heart from all sides, right? So 12 lead ECG is definitely something we would expect to be ordered. The other thing that we would expect to be ordered is lorazepam, right? So we were not given a list of her actual medications that she's been getting in the hospital, right? We were told that she takes alprazolam at home as needed, right? That's it. But we weren't given an actual order to give her anything. So we didn't have orders for anything. So as a result, we do expect the doctor to order some sort of benzodiazepine to help with the anxiety. The option we were given is lorazepam, right? So that's the one we want to give. So now, why would we not do the others, right? Because a lot of you guys chose apply supplemental O2. Remember, applying O2 at 2 liters to 3 liters nasal cannula is a nursing measure. It's a nursing measure. Nurses in the United States are allowed to apply O2 at 2 to 3 liters without a doctor's order for any patient that they think needs it. Right now, she actually is still at a good SpO2 rate of 95%. As long as she's above 93%, we don't necessarily have to even do it. But if we did do it, it's a nursing measure. We don't require an order for that. And our question is, the nurse should anticipate the physician to order, right? What should the physician order? So number one is wrong for that reason. Number two, haloperidol is an antipsychotic medication and is given for psychotic behaviors and out of control behaviors, right? That is a way big bad drug that is not necessary. It's way over the top for her situation. She doesn't need haloperidol. Lorazepam is going to be sufficient, right? A CTA of the chest, well, we don't really think she has an MI going on, right? We really are pretty sure this is related to her psychosocial disorders. So this is not going to help us take care of her and is not a priority at this moment, right? Because we don't need to see the blood vessels in her heart. Adenosine is a cardiac medication that is used for patients experiencing SVT. Her heart rate is only 119. She isn't fast enough for that, right? That's again an over-the-top medication, too much of an intervention. So if y'all guys have come to, if you're one of my students and you've come to my understanding testing errors Zoom call, we talk about making choices that are too aggressive. The Haldol and the adenosine in this question would be examples of choices that are too aggressive for the situation, right? Because that's more than she needs, right, at this point. And then vagal maneuvers, this is also a nursing intervention, right? So nursing and intervention, it does not require doctor's orders. We can have the patient bear down, hold their breath, right? Plug their nose and hold their breath and push down to do the vagal maneuver without the doctor's order, right? For a heart rate like this, okay? So that's the reason it's not correct. All right, question number 10. Which of the following interventions by the nurse are appropriate when communicating with the client? Select all that apply. Should the nurse help the client identify anxiety and triggers? Should the nurse encourage verbalization of feelings, perceptions, and fears? Should the nurse assist in developing alternative solutions to a problem? Should the nurse educate the client that mental illness defines who they are? Should the nurse explore past behaviors that have worked to relieve anxiety? And should the nurse address that the client's feelings as being unacceptable? Right? Which of these should the nurse do? Which are appropriate? Okay. Where are we? Where are we meeting? Oh, we're at Grapevine? Yeah, I'm about done on the last question. At Grapevine?
Yeah.
Okay.
I told her to send me the,
Can I ride with you?
I don't have,
Oh, you don't have a car, so you need to ride with me. I just have to stop for gas. So I'm going to be a minute because I have to stop for gas first.
literally right down the street.
Okay, good, because I have to stop for gas like right down the street at the 7-Eleven. Okay. All right, guys, really quick. Here are our answers to question number 10. Number 1 is true. Yes, we do want to do that. Number 2, yes, we do want to do that. Number 3, yes, we do want to do that. And number 5, yes, we do want to do that. So the 2 that are not correct are number 4 and number 6, because mental illness does not define who a person is. The person is much more than their diagnoses, whether they're physical or mental diagnoses. And number 6, the client's feelings are always acceptable. It's how they deal with them that could be unacceptable. But having the feelings in and of itself is totally fine, right? It's totally acceptable. But it is helpful for the nurse to help the client identify anxiety and triggers, encourage verbalization of their feelings, perceptions, and fears, and develop alternative solutions to a problem and explore past behaviors that have worked to relieve anxiety. All of those are correct. All right, guys, that is all for today. And I am going to have to go ahead and close up. I would encourage you to come back tomorrow or Thursday if you need to see these again. For any reason, we have a meeting right directly after this that I'm running late for. So I am going to have to go ahead and close out for you guys. But I do appreciate all of your discussion and questions that you gave us today. And I hope that you will come back either tomorrow or Thursday if you have more questions or you just need to see the slides again. I'm sorry I'm having to cut it short today. All right, guys, you have a great rest of your day.